so let's do this. We have the following. Now, our patient is suffering from acute kidney injury. And the acute kidney injury can be due to so many causes. So it can be pre-renal, renal, or intrinsic renal cause, or post-renal. Each one of this has its story. So I like to keep it simple for myself. I imagine the kidney only have the following three structure. So it goes something like this. If we speak about tubular problem, the problem is in the kidney itself. So I imagine, okay, this is the kidney, and it has like an ureter coming out of it, yeah? But there is something going inside of it, obviously, which is what? The artery and the vein. Okay, so she has an artery and a vein coming inside of it, and she has something going out of it, which is the ureter. And then I tell myself, okay, so if the patient has a problem of this vessel, this one is obstructed, it will be pre-renal. Or there is decreased perfusion through this, it will be pre-renal. Or there is any pathology in the body leading to less blood coming here, it will be pre-renal. If this vessel was stenosed, pre-renal again. So I'm like, okay, this is good. What about if the pathology was in the kidney itself? Well, if the pathology is in the kidney itself, it will be renal, intrinsic renal. So if the pathology is in the kidney of any form, it will be renal. Okay, what about if the pathology was after the kidney? After the kidney, I mean the urethra, or even after that, okay? If it was after the kidney, we call it post-renal. Of course, I can repeat. So we have three pathologies, okay? Pathology number one. Pathology number one is a pre-renal disease, okay? Pre-renal disease are any diseases that lead to reduction of the flow through the renal artery. Renal artery decreased perfusion. So, for example, what can reduce the renal artery perfusion? Decreased blood pressure. Heart failure can lead to less blood coming to your kidney, less perfusion. Renal artery stenosis can lead to that. You have less perfusion to that, yes? Anything that reduces the amount of the blood coming to the kidney through the renal artery lead to pre-renal azotemia, or a pre-renal acute tubular necrosis. So basically anything, any pathology that happens before the kidney will lead to pre-renal kidney disease, okay? Any pathology that happens in the kidney will lead to intrinsic renal pathology, yeah? Intrinsic renal failure. So we have the pre-renal failure, now we have intrinsic renal failure. Okay, what about if we have a pathology of the ureter? This is the ureter. If the pathology is in the ureter, we say post, it means after, post-renal azotemia, okay? So now comes the word azotemia. Does anyone know what azot mean in Latin? Azot. Nitrogen, yeah. So azotemia is accumulation of nitrogenous particles, which are more commonly to be what? What has a lot of nitrogen? A molecule that has a lot of nitrogen. That the kidney love to clear, but now she cannot clear anymore. No, your kidney don't like to clear amino acids. She has to do that actually. Yes, excellent. It's urea. It is urea. Let me see. Oh yeah, it's urea. If you take a look at the structure of urea, it has multiple H's. It has like H, 4 H's, NH4. So this will basically lead to a lot of, it's not about the hydrogen, it's about the nitrogen. There is two nitrogens here. So these two nitrogens basically are super important because when you have a lot of them inside of your body, they will lead to azotemia, okay? So let's speak about the pre-renal azotemia. In case of a pre-renal azotemia, can you tell me please, is it pathology in 1, 2, or 3? Pre-renal azotemia. 1, 2, 3. Okay, I get it. My drawing is bad. Okay, so this is the kidney. It's one. But this is the kidney. Just to make it like more logical. This is renal artery coming in it. And this is, now I'm going to make a ureter coming out of it. So if it is pre-renal, it's going to be 1, yes? So let me make it in blue. Pre-renal is 1. What about 2? Is it renal or post-renal? 2. Two is renal. And post-renal will be 3. So now we speak about a disease that leads to reduction of the perfusion to the kidney, like hypovolemia. If the patient is hypovolemic, imagine there will be less blood coming to his kidney. So it will be pre-renal. So it will be 1. Yeah? Less fluid, less amount of blood coming to your kidney, pre-renal azutemia. Okay? And if you have less cardiac output, what will happen to, let me ask this weird question. If less cardiac output, what will happen to the RAS system? Exactly, it's activated. Why? Less perfusion to the kidney. So if you have less perfusion to the kidney, that means you will have a pre-renal azutemia. Again, decrease effective circulating volume, like in case of heart failure or liver failure. Well, heart failure, we get it. Why we have less effective circulating volume? Because the heart is unable to pump the blood forward. But can someone tell me, please, why in case of liver failure, do we have a reduction of the circulating volume? Why in liver failure or liver cirrhosis so in case of liver cirrhosis, we can have decreased, which amino acid is decreased in case of cirrhosis? Albumin. And with the portal hypertension, you will have something called ascites. Ascites is movement of the fluid from your vessels, basically, to your peritoneal cavity. That is going to reduce your volume, circulating volume, from inside of your vessel to the outside of your vessel. Okay? So when you have reduction of the volume from inside of your vessel to the outside of your vessel, the amount of intravascular fluid will decrease significantly. When the amount of the fluid from your vessels will decrease significantly, that will lead to reduction of the effective circulating volume, which can precipitate to pre-renal azutemia. In the near future, I will be telling you about something called Hepatorenal Syndrome. Hepatorenal Syndrome is a defect of the liver that can lead to dysfunction of the kidney. So someone who has cirrhosis can have kidney failure. Why? Because of a pre-renal azutemia type of thing. We'll speak about it in the near future. Continuing about the pre-renal azutemia, I want you to know one thing. So, okay, let me draw this. This is afferent arteriole, this is the glomerulus, this is the efferent arteriole. Okay, can you tell me please, what happens to, just write up or down, what happens to the amount of the blood going to your afferent arteriole in a pre-renal azutemia, which was 1 up there. It was 1, pathology 1. It will be down. What happens to the amount of the blood inside of your glomerulus? Just write up or down. What happens to the amount of the blood inside of your efferent arteriole? Efferent arteriole. In case of pre-renal azutemia, I'm asking, it will be reduced as well. Less blood coming here, less blood in the glomerulus, less blood inside of the efferent arteriole. Well, the question comes like this. What will happen to the hydrostatic pressure inside of the glomerulus? It will go down. It will go down. Why? Because less flow to the glomerulus. So it will go down. So your GFR will go up or down? your GFR GFR goes down. Correct. Why? Because you have less pressure inside of here. Someone wrote no change. He's thinking smartly actually, but in a not the correct way. You will know why in 1 second. What happens to the renal plasma flow? Renal plasma flow, it's down. Correct. Why? Because the renal plasma flow resembles the blood going to the afferent arteriole or to the glomerulus or to the efferent arteriole. Which one of these is resembled? Efferent arteriole, efferent arteriole. Exactly, because the efferent arteriole connects with the peritubular capillary, yeah? So the renal plasma flow is how much blood is making it to the peritubular capillary, which is how much blood going to the efferent arteriole, basically. Okay, so if the GFR is reduced and renal plasma is reduced, what is going to happen to the filtration fraction? Now comes your time, the person who said no change. No change. Why? What is happening to your GFR? What happened to the GFR? Actually, why I'm tiring myself, just like this. Here is FF, and it's equal to GFR divided by renal plasma flow. GFR is low. Renal plasma flow is low. Low and low, filtration fraction will be the same. Yes? No change. Got it? Okay, let's go back. So decreased renal plasma flow. Excellent. Renal plasma flow will be low. And there will be low GFR. And here they even mentioned the renal blood flow, but it's okay, the same thing. Low GFR, if you have low GFR, really low GFR, the filtration will go, filtration fraction is normal, but the actual amount of fluid going from the GFR represents the filtration itself, but not the filtration fraction. So the amount of the blood filtered will be a bit like lower than usual. So tell me please, inside of the proximal tubule, the speed will be fast or slow, do you think, in this situation? If when you have less amount of blood going through, less pressure inside of the glomerulus, the amount of speed going through the proximal tubule will be faster or slower? Actually, here it's a bump, so it's a pressure, yeah? So now the pressure is much less. So it will, instead of being like, it's like, everybody loves somebody. It takes a lot of time to pass. So when it takes a lot of time to pass, the flow here will be much more slower. And when is it easier to reabsorb? With a slow flow or with a fast flow? With a slow flow. So basically, when you have less GFR, you are going to have what also? Less amount of urine going where? What the hell? Okay, so if you have less GFR, what is going to happen? You will have less amount of urine breaching what? What receptor do you have inside of your distal convoluted tubule that sends sodium? What is the name of that receptor? Sends sodium, not the pressure. Macula densa. In this condition, you have less flow, slower flow. So what is going to happen to the amount of pressure and sodium, amount of sodium reaching the macula densa? It will be reduced. Slow flow. So less sodium coming here. That will lead to activation of which system? Excellent, the RAS system. What, somebody, I feel like somebody wrote the answer before me even asking the question. Okay, so the RAS system. Okay, the RAS system, that's correct. When the RAS system is activated, you will have what? More angiotensin 2, yes? More angiotensin 2. Do you remember when we spoke about the picture that I told you that it's really annoying, but there is a lot of equation that comes from it? This is one of the most difficult 10 pictures in the whole book. This is one of them. And there will be angiotensin 2, and that will lead to more reabsorption of sodium from where? from your BCT, proximal convoluted tubule. So here we go to it again. Okay, so you see what they write. More reabsorption of sodium and H2O and also urea. Okay, so urine osmolality will be really high actually. It will be more than 500. Why? Because the filtration is less and more reabsorption. Guys, if you are reabsorbing a lot of water from the tubules, are you concentrating the urine or are you diluting the urine? You are sucking the water out of it. So is it getting concentrated or diluted? Let's imagine that this is the tubule. This is the tubule. It has, let's say, sodium, for example, and also a lot of water. It has some urea. It has so many other substances, and you are sucking only water from here. So the concentration will go up or down? Up. Excellent. The concentration will be up. Urine osmolality is going to jump up. So now comes the question, why the hell urine sodium is low? And the FeNA, fractional excretion of sodium, is also low. The answer comes, we just spoke about it. When we had reduction of the flow to the macula densa, we had activation of which system? I will tell you in a second. RAS system. RAS system activated which channel? The angiotensin 2. The sodium channel led to reabsorption of the sodium. That increased the urine osmolality initially. Sorry, that, no, not the urine osmolality. That lead to what? Sucking of what? The sodium. Take a look. Reabsorbing of the sodium. Let's take a look. See, here the sodium is getting reabsorbed at a massive amount. A massive amount of sodium is getting reabsorbed. Good. So, oh, by the way, really quick recap of this concept, just for 1 minute. Remember that when the sodium is reabsorbed in, what goes out? Hydrogen. When hydrogen goes out, it will bind to bicarbonate. Bicarbonate was just filtered from the kidney, so it was going to the urine. When it met hydrogen, they met each other and they were like, wanna make a baby? He was like, sure. So they binded to each other and made bicarbonic acid, in which it was made, converted to H2O and CO2. These two substances were reabsorbed by the BCT, and then you made bicarbonic acid out of them again. And then the bicarbonic acid was made bicarbonate and hydrogen. The bicarbonate was sucked inside of the body. So this whole process, in short, moved the bicarbonate from the lumen to the blood. So this whole process that happened here, the movement out of the H, led to reabsorption of the bicarbonate. Is that leading to alkalosis or acidosis of the blood? Alkalosis, good. So this is the concept of contraction alkalosis caused by angiotensin 2. Good, let's keep moving. It's just like sometimes I will be recapping this 30 seconds recap, we call it. We do it really fast. I tend to do it more often when you get the concepts, guys. Like when we do more systems, so you start needing to correlate system with each other, so I can speak with you more freely. And we already finished, this is our third system. We are going to finish pretty soon in 2 days. So yeah, from now on, it's going to become more easier for you. Okay, so let's keep going. FeNA. Somebody asked, what is FeNA? A fractional excretion of sodium. You're like, what the hell is fractional excretion of sodium, man? Well, I'm like, wait a second. So the reabsorption of sodium in the before one led to reabsorption of sodium. So the sodium concentration will be low. The fractional excretion of sodium is what? Well, you have your tubules here. And I have the question. The movement from the glomerulus to the Bowman's capsule, what do we call it? Filtration, reabsorption, secretion, or excretion? Choose it quick. Filtration, excellent. I always give the right answer after the third person writing. Good. The movement of the substance from the BCT to the peritubular capillary, what do we call it? Okay, that's one person. That's two persons. Okay, come on. Excellent. So it's reabsorption. Movement of the substance from the peritubular capillary to the sexy. No, it's secretion, man. Come on. It's a respectful group. Don't write that here. Okay, what about the movement from the collecting duct to the outside of the body? Excretion. Excellent. So when I'm telling you the fractional excretion of sodium, it means like how much sodium was excreted, compared to how much sodium was filtered. So if you compare the sodium excreted, okay, to the sodium being filtered, you get a fractional excretion of sodium. Well, you're like, okay, so what is this, like less than 1%, more than 2%? What does it mean? Well, guys, in case of a pre-renal azotemia, is your tubule dysfunction, is the problem in your tubules or is it somewhere else? Exactly, in a pre-renal azotemia, it's somewhere else. It's not in your tubules. The question was, in case of a pre-renal azotemia, is the problem in your tubules or the problem is somewhere else before your tubules? It's somewhere else before your tubules. Heart failure, dehydration, renal, for example, renal artery stenosis, all of these are before your kidney, yes? Okay, so in this condition, it's before the kidney. Good, we agree on this. So your tubules are functional. They are fully functional. So will your tubule be able to reabsorb the sodium? The answer is yes, they can. They are intact. They don't have any pathology. They will be able to reabsorb it for 100% or almost 100%. So if they can reabsorb it normally, the sodium inside of your urine is supposed to be high or low? If your tubule, yeah, really low. If your tubules can reabsorb the sodium perfectly, the fractional excretion of sodium must be less than 1%, which means the pathology is not in your tubules. So when the FeNA is less than 1%, I'm telling you that the pathology is not in the tubules. It's before the tubules, not me. The Usmle is telling you, when he gives you the FeNA less than 1%, he's telling you the pathology is not in the tubule. The tubules are intact. While in intrinsic kidney disease, notice, intrinsic kidney disease, the problem is in the tubule. So, will you be able to reabsorb normally or not? You will not be able to reabsorb normally. So, the amount of sodium getting excreted, will it be higher or lower if you are not reabsorbing? Yes, much higher. So when it's much higher, the FeNA will go up. More than 2% is considered really high. Good. Excellent. Let's keep going. So, yeah, guys, just keep that in mind. Every single system, in the beginning, it sucks. After sometimes it starts becoming interesting and then it becomes like really fun to learn. It happens in every single system. Just you need to give it time. So speaking about the serum, the FeNA, less than 1%, we got this point. Let's keep going. Serum BUN to creatinine ratio. BUN, blood, urea, nitrogen. Blood, urea, nitrogen, which is the amount of nitrogen inside of your blood compared to the clearance inside of your kidney, clearance of like creatinine. So I have this question. If the pathology was pre-renal, it means that the main pathology is not from your kidney. It's somewhere before your kidney, correct? If it is somewhere before your kidney, will your tubules be intact or not intact? Intact. Good. Intact. Well, it's intact. So when they are intact, can they reabsorb urea? They can reabsorb urea. So if they can reabsorb urea, your BUN is going high or low? what is going to happen to your BUN if you reabsorb urea? Remember, blood, urea, nitrogen. It means how much urea is in your blood. So if your tubules, if your tubules can reabsorb urea, your BUN is going up. Yes? So your BUN will be high. Okay? Okay. So what about your creatinine? It also is going to be high, but not as high. Yes, of course I can. This is important concept. If you don't get it, I'm ready to re-explain it 3 times because you must get this one. So BUN to creatinine ratio. Okay? So if we say the pathology is pre-renal, are the tubules dysfunctional or functional? Can the, just write yes or no. Can the tubule reabsorb if it was pre-renal? Yes, they can. They can reabsorb, all good. Why? Because it's pre-renal. The pathology is not in the kidney mainly. Okay, so they can reabsorb. So can they reabsorb urea? Remember, urea is also reabsorbed at the medullary portion of the collecting duct. So yeah, they can reabsorb urea. This is correct. Good. So they reabsorb urea with no problem. Good. So they reabsorbing urea. So the blood urea nitrogen is how much nitrogenous material you have inside of your blood. Okay. So urea is a nitrogenous material. So when you have more urea reabsorption, is getting reabsorbed into your blood. So what is going to happen to your BUN, which is blood urea nitrogen? It's going to be up or down. Okay, one more person to write. Come on, come on. Yes, it's going to be high. So your BUN, okay, again. So one more time. We have a disease called pre-renal azutemia, and we have renal azutemia. Pre-renal azutemia, it's a pathology in 1, 2, or 3. Tell me please, is the pathology in 1, 2, or 3? It's in 1. Okay, the pathology is in 1. So if the pathology is in 1, is your kidney functional or not? Yes or no? Until now, yes, it's functional. Good. You did not have infarction of your kidney yet. So it's still functional. Okay, it's still functional. So your tubules are functional or not functional? Okay, they are functional. So can they reabsorb substances? Yes or no? Remember, reabsorption is the movement from the tubule to the peritubular capillary. Can you reabsorb? Okay, you can reabsorb, no problem. Can you reabsorb sodium? Yes, you can. Can you reabsorb urea? Can you reabsorb glucose? Can you reabsorb amino acid? You can reabsorb everything. Just to make it simple, your tubules are functional and you can reabsorb everything, okay? So if you can reabsorb everything, what is going to happen to the amount of urea here? Will it be reabsorbed or it will just be cleared out? It will be reabsorbed, yes? Why? Because you still can reabsorb it. So let's reabsorb it. You are taking urea from the tubule here and you are moving it to the blood. This is the blood. It's moving to the blood. When you have more urea in the blood, what is going to happen to the level of urea inside of your blood? It's going to be high. Yeah? When your urea inside of the blood is high, this is going to increase something we call BUN, okay? So simply, BUN is proportionally related to the amount of urea inside of your body. So your BUN is going to be much higher than usual. And if you compare it to the creatinine, which is a substance also cleared and filtered from your kidney, this guy will also be high, but not as high as the BUN. BUN will be much more higher. So the ratio between the two will be high, okay? And that's why BUN to creatinine ratio is higher in case of a pre-renal azotemia than other conditions, okay? So if someone is still not getting it, please write me in private and we can discuss it together. So intrinsic renal failure, it goes something like this. The problems is in the tubules or in the interstitium. Multiple causes, for example, acute tubular necrosis can cause it. What can lead to acute tubular necrosis? Well, we'll speak about them soon, but just for the sake of doing it quick and dirty, ischemia. Which portion of your kidney is most susceptible to ischemia? Let me give you a hint, the watershed area. Okay, BCT, that's correct. What else? The thick ascending lobe of Henle. Well, the BCT and the thick ascending lobe of Henle, is it mostly the medullary portion or the cortical portion that will be affected? Medullary, always medullary. Be careful about this one, it's here. I know that it's between the lines, but you need to learn how to read between the lines. It's basically where are you? Okay, so it's basically between the lines. They hide it inside of here. See? So the kidney, the straight segment of the proximal tubule is located in the medulla, and the thick ascending limb is located in the medulla. Okay, good. Let's keep going. So, guys, like always, when I start looking at the system and I start moving from like the next system and going backward to reach the material I want to explain to you, you must know we are almost done with the system. So, nephrotoxins, for example, the contrast we use for the CT scan. Some drugs we will speak about in the future. They are nephrotoxins and they love to kill your BCT as well. Guys, why do you think the BCT is the most likely place for where most death of the kidney happens? Like, it's the most susceptible area in the kidney for injury. Why? Exactly, it works the most. It's the most functional area inside of your kidney. It requests the most amount of ATP inside of the kidney. Thus, it's highly susceptible to get ischemia. And it has like, if you compare it to other areas, it has the same blood supply as other areas, but it does 100 times more function than anybody else, you know? So it needs more, it has higher O2 demand than other places, okay? So, okay, let's speak about the glomerulus. Oh, okay, also acute interstitial nephritis, we are going to speak about it soon. Basically, this is a form of hypersensitivity reaction of the kidney against some drugs. Also, except the tubular and the interstitium, the pathology can be in the glomerulus. Remember, your nephrons is made from your glomerulus and your tubules and the vessels going around your tubules, yeah? So if the pathology was in the tubules, it can be these two. The glomerulus, it can be acute glomerulonephritis, which we spoke about so many types of it. We spoke about an IgA glomerulonephritis. We spoke about post-streptococcal glomerulonephritis. Can someone tell me which type of cast we are going to see in glomerulonephritis? Which type of casts? Cast. RBC cast, exactly. We are going to see RBC cast. A granular cast is mostly seen in acute tubular necrosis, not in case of glomerulonephritis. So, okay, so the next one is vascular. For example, vasculitides and malignant hypertension and also TTP-HUS. Well, someone is going to tell me, you remember about a disease called arteriosclerosis. This arteriosclerosis had two types. It has this Mockenberg arteriosclerosis and arteriolosclerosis. Yeah? Malignant hypertension lead to arteriolosclerosis. But arteriolosclerosis had two subtypes. It had the hyaline arteriolosclerosis, and it had the hyperplastic arteriolosclerosis. If we speak about malignant hypertension, is it leading to hyaline arteriolosclerosis or hyperplastic arteriolosclerosis? This is a question from between the lines. If you know this is mean your level is high. Let's see. Let me repeat this question. If a patient has malignant, we had a condition called arteriosclerosis. And it has two subtypes, the Mockenberg or medial calcific sclerosis, and another type, it was arteriolosclerosis, okay? So arteriosclerosis had the hyaline subtype, and they had the hyperplastic subtype. In case of malignant hypertension, which one are you going to have? Is it the hyaline, hyperplastic, or the Mockenberg? Hyperplastic, exactly. Hyperplastic is in malignant hypertension. What about essential hypertension and diabetes? Essential hypertension and diabetes. Essential hypertension and diabetes is the hyaline. Excellent. Good. Okay, good. That makes me happy because you remember exactly what I was telling you. So in acute tubular necrosis, patchy necrosis will be seen. Debris will be obstructing the tubules, and the fluid will have a backflow leading to obstructive the flow. You're like, what the? Well, let me tell you what the. So if you take a look here, come on. So here you have your tubules. In case of acute tubular necrosis, these tubules are dying, yes? And let me get the color brown. Okay, so these are dying, and when they are dying, they are falling inside of the lumen. Yes, and they keep moving inside of the lumen, move, and then they are doing what? They keep moving inside of the lumen, and then they are doing something like this. Okay. What the? No, they are not doing this. So basically, after that, they will start moving, yeah? And that granular cast will go outside. Basically, this was the formation of a granular cast because there was destruction of these guys. So the granular cast now just went outside of your body, and you can see it in the urine. Yeah? So if you take a look at the urine, you will see what is breaking, my voice or the granular cast. Man, you are scaring me. Oh, okay. So my voice. Okay, let me try. Maybe it will work better like this. Is it better? Oh my, okay. Okay, so can you see my screen and hear me clearly? Can you hear? Okay, excellent. So let's speak about this. So the granular cast is now moving to your urine, okay? So it's going to your urine and it's just this guy and he's moving, okay? And it's moved from your kidney all the way until it exited your tubules. So the next thing is this. They write, this acute tubular necrosis led to the debris moving out and blocking the tubule. So the tubule now is blocked. So tell me please, if the tubule is blocked, what is going to happen to the pressure at this point? Is it going to be up or down? Okay, it's going to be up. If it's going to be up, it's going to increase the hydrostatic pressure of the Bowman's capsule, yeah? Increasing the hydrostatic pressure of the Bowman's capsule will reduce the movement from the glomerulus to the Bowman's capsule. So what is going to happen to the GFR? It will be reduction, it will be down, exactly. Good. Okay, so here you can see in acute tubular necrosis, there will be batchy necrosis, debris obstructing the tubules, and the fluid backflow, which decreases your GFR. Okay, so this made sense. Let's keep going. Urine osmolality. Well, in acute tubular necrosis, guys, is your kidney reabsorbing normally or not? No, your tubules are not able to reabsorb. So the osmolality of the urine will be less than 350 because you are unable to reabsorb. Okay, what about your urine sodium? Are you able to reabsorb normally? Again, can you reabsorb sodium normally? You cannot. So if you cannot reabsorb sodium normally, what will happen to the urine sodium level? Up or down? Up, yes. Okay, so what is going to happen to your fractional excretion of sodium? Which is the amount of sodium getting excreted compared to the amount of sodium getting filtered. Yes, much higher. Why? Because you do not have reabsorption. The last thing is serum BUN to creatinine ratio. Well, you cannot reabsorb the BUN. So what is going to happen to the BUN? You are not reabsorbing urea. Okay, it will be down. And your creatinine will be really high because this is kidney failure basically. So what is going to happen to your BUN to creatinine ratio? The whole ratio between the two? Yes, exactly, it will be low. Okay, good. So you can see it's less than 15. So the last cause is post-renal azotemia. Post-renal azotemia is a pathology affecting 1, 2, or 3 guys. Okay, it's affecting 3. That's correct. So this can be a stone. It can be benign prostatic hyperplasia, neoplasm blocking the outflow, or congenital anomalies like a posterior urethral valves. Basically, they lead to outflow obstruction, but it must be bilateral. It cannot be one kidney compensating for the other. So in that pathology, basically your urine osmolality, it's okay, it's fine, you know, it will not be increased. And the other ones, it varies according to the cause, so we cannot speak about them, except when we speak about each pathology on its own. Speaking now about the last thing before the break, acute interstitial nephritis. I want you to know that this is basically the asthma of the kidney. It's a hypersensitivity reaction. It's in which the kidney becomes basically sensitive to these substances. So acute interstitial nephritis, also called the tubular interstitial nephritis. Acute interstitial renal inflammation, okay? And biuria, classically eosinophils. Why? Because I told you it was a type of hypersensitivity reaction. And to make it actually more, you can write a note about this. It's type 2 and type 4 hypersensitivity reaction together. So it's an acute interstitial renal inflammation. There will be biuria. Biuria, it's white blood cells inside of the urine. Classically eosinophils. The problem is interstitial, so it's near the tubules. Will we have a cast in this pathology or not? It's affecting the tubules. So will you have a cast? Excellent. It will have a cast because it's affecting the tubules. So as you can see, it's tubular interstitial nephritis, so it will have a cast, and the cast will be white blood cells, and these white blood cells will be eosinophils, okay? So when you see, actually, let me give you this trick. If you see a cast that has eosinophils inside of it, don't think it twice. It is which pathology? Acute interstitial nephritis. I love this pathology because it was one of my first diagnoses that I made in my life. It was really interesting. She was a young lady, and I'm telling you the story because when we read about this disease now, it will make sense. She was a young lady that came to the hospital. I was a second-year trainee, basically still in Jerusalem. And this lady came to me and came to the hospital, and she was around 13 or 14. And she came and we did a urine analysis on her, and guess what? White blood cells in the urine. But the urine analysis, basically it was a dipstick, so it does not tell you exactly what it is. So they took blood from her and they took urine for further investigation. The blood analysis came back quickly actually, and it was written in it that she has eosinophilia. I was a second-year medical student. I was like not that smart, so I opened Google and write eosinophilia. So I found out that, okay, started reading about this pathology. Then I came back to her and I checked that it has a relationship with parasite, the eosinophilia, the interstitial nephritis, leukemias, a lot of things. So my question was to her, when was your last menstrual cycle? And she was like, it was 5 days ago. And I was like, did you take any analgesics? She was like, yeah, I take this analgesics. I'm not sure which one it was. I think it was indomethacin. But basically she took a lot of it. Okay? And she was like, it's the only thing that helped the pain to go away. I was like, excellent. So basically what she has a hypersensitivity reaction against this drug, leading to acute interstitial nephritis. Yeah, so that's important pathology to know because it's widespread. It's all over the place. Okay, biuria, especially eosinophils and azutemia, that occurs after administration of drugs that acts as a haptan. Well, haptans are basically substances that normally are not antigen. They are not acting as antigens, okay? But these haptans, they are not basically antigen, but if you give them the correct type of basically carrier protein, they will start acting as an antigen. Basically, you either need to be precipitated to having this from like a genetic point of view. Like I just want to send this picture. Actually, I have it on my phone. Here you go, guys. I just sent a picture on Telegram. And you can see that these haptans basically are molecules that do not lead to immune response. But when you have the carrier protein, in which you might have it like because of your genetics, you can have a hypersensitivity reaction. Okay, so as a haptan, inducing hypersensitivity reaction, it could be diuretics, it could be NSAIDs, penicillin derivatives, protein pump inhibitor, rifampin, and quinolones, which are antibiotics. Also, sulfa drug. Less commonly may be secondary to other processes such as systemic infection like mycoplasma pneumonia, or autoimmune disorder like Sjogren's disease, lupus, or sarcoidosis. When we do either of these stuff, we are going to come back to acute interstitial nephritis because it's basically so many things cause it. So you would like to diagnose it not according to the cause, you would like to diagnose it according to the labs, the eosinophils. So it's associated with fever and a rash. Why rash? Because it's a hypersensitivity reaction. And hematuria. The patient will have costovertebral angle tenderness, but can be asymptomatic sometimes. The lady who came to us to the hospital, she had a really bad costovertebral angle tenderness with negative kidney ultrasound. That made us like even more suspicious about this case. So remember the 5 P's. So P, which is diuretic, pain-free, NSAIDs, penicillin and cephalosporin, proton pump inhibitor, rifampin, and sulfa drug. Add albuterol, which is an anti-gout drug. Okay? Well, if we speak about acute interstitial nephritis, is it a form of a pre-renal azutemia, intrinsic renal failure, or post-renal azutemia, guys? Tell me, please. It's intrinsic. Well, if it's intrinsic, your BO and creatinine ratio, will it be high or low? It will be low. That's correct. Okay, So that's it for this session, but we will have one more session now in which we will discuss acute tubular necrosis, diffuse cortical necrosis, and hopefully renal papillary necrosis. So let's just take a 5 minutes break. We'll be back in 5 minutes.